Bismillah ar-Rahman ar-Rahim. I am Professor Dr. Shireen Musallam, Professor of Medical Parasitology. Today's lecture is about the Strongyloidies Stercoralis, and it's one of the intestinal nematode lectures in Module 17. Strongyloidies Stercoralis is a threadworm, and it is prevalent in the tropical and subtropical areas where poor sanitation, warmth, and moisture are mainly present. Depending on the environmental conditions, this worm can either live freely in the soil wherever the conditions are appropriate. This means that wherever there is warmth and moisture, it can live for a very long time in the soil. But if these conditions are inappropriate for one reason or another, it can interchange from the free living state into the parasitic state. In the parasitic form, it can live in the small intestine of humans, where males are present in the lumens, whereas fertilized females are deeply embedded into the mucosa. The interchange between the free living form and the parasitic form, this makes the worm to be called facultative worm. Strongyloidies Stercoralis is called the facultative worm because it can live either freely in the soil, or can parasitize humans, or can interchange between the two phases. Morphologically, Strongyloidies Stercoralis is a nematode. That's why it has a cylindrical body, whether male or female, whether free living or the parasitic form. All forms possess a small buccal capsule, and its posterior end is always tapering, whether male or female, but the male possess posterior simple spicules. Always, nematodes have a characteristic feature in which females are always longer than males. But in case of the parasitic form, the female is much longer than the male. The female of the free living or the parasitic forms possess what we call a vulva for the production of the eggs. In the free living form, it is present just around the equator, whereas in the parasitic form, it is present in the posterior 1/3 of the body. Let's just agree for a few things which will facilitate the life cycle when we take it. Once adults are present and are sexually mature, females are fertilized to produce the eggs. And the eggs of Strongyloidies Stercoralis are characterized by being partially embryonated eggs having a thin shell. Eggs then hatch to produce the rhabditiform larvae. Now let's concentrate in this next part, please, because this will explain a lot about the life cycle. Rhabditiform larvae need to molt in order to continue the life cycle. It is dependent on the environmental factors and the number of molting. If environmental factors are appropriate, it will molt 4 molts in order to generate the mature adults. That's why in the free living form, rhabditiform larvae can directly change into mature adults by molting 4 times. Alternatively, it can molt 2 times to form the filariform larvae, which is the infective form for the humans. In this case, filariform larvae will enter into the body to molt twice again in order to form the mature adults. So again, let's revise this part, please. It all needs 4 molts. If conditions are appropriate in the environment, the rhabditiform larvae will directly molt 4 times to produce the adult, and the life cycle will continue in the soil. But in case that the life cycles have been good or appropriate for a while, it will just molt 2 times to form the filariform larvae. Once the environmental factors are disturbed, it will just penetrate a host like humans in order to molt inside the body of the host to form the adult. Now, there are three modes of transmission of this nematode. Either direct form of transmission, indirect form of transmission, and auto-infection. Of course, in the auto-infection, man is the source of infection for himself. But both in the direct and indirect forms, the worm needs the soil to continue its development. The rhabditiform larvae have to descend into the soil in order to molt. And it depends. If it molts 2 times, then this is direct transmission, but if it develops 4 times, this is indirect transmission. Let's explain what we have just said collectively as for the direct transmission. As we said that inside the humans, males and females inhabit the small intestine, where the males live in the lumen, but the females are deeply embedded into the mucosa. This is the female, and it is deeply embedded into the mucosa, producing eggs. Once the eggs hatch, they produce the rhabditiform larvae, and these larvae are liberated with the stools from the intestine. When they descend into the soil, if conditions are unfavorable, they will directly change by molting twice into the third form, filariform larvae, and they will wait for a human to pass by in order to penetrate their skin. So in this case, the infective stage is the third stage filariform larvae, and the mode of infection is through the penetration of the skin. Why did we say that this is the direct method of transmission? Simply because the rhabditiform larvae just molted twice and infected another man. It didn't continue to proceed its whole life cycle in the soil. That's why it's a direct infection from man to another man. Once the infective stage penetrated the skin of a man walking, for example, with bare feet or something, it will jump into the circulation. The circulation will send the filariform larvae to the lungs, where they will penetrate the alveoli, and they will walk or they will travel up retrogradely until they reach the esophagus. They will be swallowed, and they will pass through the small intestine until they reach their habitat, which is the small intestine, and there they will make another 2 molts to form the adult, where it will inhabit the intestine. This is the direct mode of transmission without passing through adult stage in the free soil. Speaking about the indirect form of transmission, again, we will start from the female after being fertilized and after being embedded in the mucosa of the small intestine, and it is liberating eggs. And as we said before, the eggs are characterized by being partially embryonated with a thin shell. These eggs will hatch, and they will release the rhabditiform larvae, and the rhabditiform larvae again will descend with the soil. And from here, from this point, we will speak about the indirect transmission. If soil conditions are favorable now, which means that there is good moisture and good temperature, so this part, this green part, is the indirect transmission, where the rhabditiform larvae will molt 4 times. As we said before, that once there are appropriate conditions, it will molt 4 times to form the free living adult. Free living adult again will produce eggs. Eggs will hatch to form the rhabditiform larvae, and the rhabditiform larvae will turn into the adults again by 4 molts. This will continue for a long time, as long as the conditions are favorable. Again, the rhabditiform larvae will molt 4 times in order to form the free living adults. Free living adults will produce the fertilized eggs, and it will hatch to release the rhabditiform larvae, and this will continue, as we said, in the soil as free living adults. But once conditions after a long time or even a short time of a free living phase, once conditions are no more favorable, desiccation happens, temperature lowers or something, the rhabditiform larvae won't be able to molt 4 times to continue the free living form. It will just molt 2 times to form the filariform larvae, and as we agreed, this filariform larvae is the infective stage. It will inhabit or it will infect humans through skin penetration. And then life cycle will go on again. This, the filariform larvae will penetrate the skin, it will jump into circulation, and then the circulation will send it to the lungs. It will penetrate the alveoli and walk retrogradely till they reach the digestive system, and they reach the intestine, small intestine, which is their habitat location. And this is the indirect form of transmission. Why did we call it indirect? Simply because at one phase of its life cycle, it resided, this nematode resided or lived in the soil in the free living form. As for the autoinfection, we both agree that autoinfection means that human is the source of infection for himself. What does this mean? Does this mean that the rhabditiform larvae won't reach the soil to molt even twice? No, it will not reach the soil. Everything will happen inside the intestine. How does this happen? This happens in constipated patients. In constipated patients, stool is retained for a long time inside their intestines, and that's why there is good time and good conditions for the rhabditiform larvae to molt twice inside the human's body and not outside. Inside the human's body, it will molt 2 times to form the filariform larvae. This happens only in constipated patients, and the stool is a good medium for the favorable conditions because it is moist and it has a good temperature. That's why once time is prolonged for the presence of the rhabditiform larvae inside the stool of a human, it can change from the rhabditiform larvae to the filariform larvae, and it will infect this man, or this person will infect himself, and this will lead to persistence of Strongyloidies Stercoralis infection. It will not just pass by. No, this person will keep on infecting himself for a prolonged time. What are the types of autoinfection? We have the internal autoinfection, the external autoinfection, and the hyperinfection, and we will take each type in details. In the internal autoinfection, as we agreed that the rhabditiform larvae will change to filariform larvae during their passage down the bowel. This happens, as we agreed, in constipated patients. But the difference between the internal and the external autoinfection is that when did this rhabditiform larvae change to filariform larvae? If this change happens early at a higher level, so the filariform larvae will invade the mucosa of the intestine, and it will pass through the portal circulation and continue its journey to reach the lungs. But if the rhabditiform larvae is changed into the filariform larvae down in the rectum or something, so this filariform larvae will invade the perianal or the perineal skin, and it will pass to the systemic circulation to the lungs. The fate in both cases is the same. In both cases, internal autoinfection or external autoinfection, in both cases, the filariform larvae will reach the circulation to the lungs, and it will continue its life cycle. The only difference is that will it change to filariform larvae at a higher level. If this happens, so it will invade the mucosa and pass through the portal circulation, then go to the systemic. But in the case of the external auto-infection, this change, this transformation from one larva to the other, to the infective larvae, happened at a lower stage. So just near the perineal or the perianal skin. That's why once changed at this level, the filariform larvae will jump and it will penetrate this skin into the systemic circulation. But anyway, both external and internal auto-infections will lead to the same fate. In both cases, filariform larvae, after penetrating whether the mucosa or the perineal skin, they will pass to the circulation and back to the lungs in order to, as a transitional migratory phase, in order to reach the GIT to go to their final habitat, which is the small intestine. What about hyperinfection? Hyperinfection happens when there is a disturbance in the equilibrium of the immune status of this host. There should be, normally, there should be a good immune balance between the parasite and the host, between the Strongyloides stercoralis and the man or the host. But sometimes, some patients are immunosuppressed. That, for example, they are under corticosteroids therapy, they are taking immunosuppressive agents, they are passing through some conditions like chronic infections, burns, irradiations, malnutrition, cancers, or even AIDS. In such case, the immunity of this patient doesn't allow the body to control the infection. So infection will be in a severe, persistent, prolonged state, and this is hyperinfection, severe, persistent, prolonged type of autoinfection which happens in immunosuppressed patients. Speaking about the clinical presentation of a patient suffering from Strongyloides stercoralis, as any other infection, if this is a very light infection, the patient might pass by asymptomatic, and of course clinical pictures can be divided according to the stage. We have the first stage is the penetration of the filariform larvae into the skin, the infective stage into the skin. So the first stage is the cutaneous stage. This is followed by the entrance of the larvae into the circulation to reach the lungs, and this is the transient migratory pulmonary phase. And then finally it would reach the intestine, and this is the final stage. So we are speaking about 3 stages. The preliminary cutaneous invading stage, followed by the transient migratory pulmonary stage, again of the filariform larvae, then the stage of maturation in the intestine. So clinical pictures or clinical presentations will be linked to each stage. Once in the penetration stage, there will be mild cutaneous infections which could pass by unnoticed by the patient or could be noticed, such as petechial hemorrhage at the site of penetration of the filariform larvae, the infective stage, itching and erythema. The second stage is the pulmonary stage, where the larvae will pass through the lungs. Which larvae that pass through the lungs? We are speaking about the filariform larvae. Filariform larvae just pass through the lungs in order to reach their final habitat. So this is not their habitat. They're just passing by, but still the body will deal with them as if there is a foreign body inside the lungs. This reaction of the body or of the lungs to the passing by filariform larvae in the lungs will produce what we call Loeffler's syndrome. And what is a Loeffler syndrome? It is an asthma-like syndrome. This patient will suffer from cough, shortness of breath, wheezing, and even fever, or even hemoptysis. This is caused by the reaction of the lungs towards the foreign migratory larvae inside the lungs, where this reaction will result in pulmonary infiltration with inflammatory cells, mainly eosinophils. And this is the cause of the Loeffler's syndrome. Now we reach the final stage, which is the intestinal stage. And again, there are light infections where the number of infecting larvae is not huge. And this is light infections. The patient will just suffer from some abdominal pain and diarrhea, which will be non-specific in this case. But in heavy infections, where there are huge numbers of adult Strongyloides stercoralis residing in their natural habitat, which is the small intestine, where the female is penetrating the mucosa, this will cause affection of the mucosa due to the high number of adults. This could lead to malabsorption, of course, because the function of the small intestine is the absorption of the nutrients. This will lead to malabsorption, resulting in steatoreic stools, and of course, it will lead to weight loss due to malabsorption. In some severe cases, ulceration or sloughing of the mucosa happens due to the penetration of the anterior two-thirds of the female, of the fertilized female, into the mucosa. This happens if the number of infection is high. Of course, as any nematodes or as any worms, the body reacts by the high eosinophilia. It is a characteristic, important feature of this nematode and others. Upon speaking about hyperinfection, in which we said it is a form of auto-infection in immunosuppressed personnel, in which the immune system is impaired in these patients, so the infection is flared up. Huge or massive number of larvae are being produced all the time, and these massive numbers will disseminate. They will not follow the normal pathway. They will not go from the circulation to the lungs and back to the intestine. No, this augmented severe state, it will not be under control. The immune system is not controlling the normal pathway. That's why these massive numbers of larvae will start disseminating in different visceral organs, and that's why we call it stimulates visceral larva migrans syndrome, in which the larvae keep on migrating into the viscera or the different organs, affecting the organ that it will pass through it. It depends which organ is affected. It can go to the liver, it can go to whatever organ it goes to. The second point, the second dangerous point of this hyperinfection is that when the larvae are passing through the lungs, and as we said before in the Loeffler syndrome, the reaction has happened against the passing by filariform larvae. But sometimes when immunity again is depressed, the huge numbers of larvae passing through the lungs, they will be interrupted by the tissue reaction, and this will cause that these will stay there in the lungs for a long time, allowing it to develop, to molt twice, to form the adult form. And once it is formed, the adult form is formed in the lungs, which is not their normal, natural habitat. This will lead to continuity of the life cycle inside the lungs. The adult will think that it is living in the intestine. It will keep on producing the eggs, and eggs will hatch to produce the rhabditiform larvae, and rhabditiform larvae will develop and it will molt 4 times to form adults. All these phases will occur inside the lung, and this is a catastrophe, of course, because this will affect the pulmonary function. So this is the danger of hyperinfection. Either, what is the cause? It is the cause of impairment of the immune system. This will lead to massive number of productive larvae. What is the fate of this huge number of larvae? They will not be released. They will start acting in a strange way because there is no immune control on them. They will either disseminate and affect different organs, and the others depends on the organ it will go to. Or it will go to the lungs, again as a form of dissemination, but in this time, complete maturation happens in the lungs, destroying the lung tissues and leading to even pulmonary failure. Diagnosis. How can we diagnose a case of Strongyloides stercoralis? It could be, if it is a light infection, it could be accidentally diagnosed through the eosinophilia. Maybe this person is just making complete blood picture analysis and he finds high eosinophilia. This high eosinophilia could be linked to parasitic nematode infection. Now, if this patient is symptomatic and is presenting with GIT manifestations or whatever, this will lead to trying to find, this will lead the physician to try to follow the correct route of diagnosis to capture the diagnostic stage. And in this stage, in this phase, the diagnostic stage is the rhabditiform larvae. Where can we capture the rhabditiform larvae? From the stool. So this patient should present stool samples. What is the diagnostic stage? The rhabditiform larvae. Okay, this can be present in the fresh stools. Is there any chance to find the filariform larvae in the stools? Yes, of course. This can happen if this patient is constipated. The stool kept there or retained inside his body for a long time will allow the rhabditiform larvae to change into filariform larvae. Is there any chance of finding other stages? Yes. We can find the embryonated eggs in the stool. How can this be? This happens in patients with severe diarrhea or patients who are taking purgatives. In these two cases, the eggs are passing by all stages, are passing by the stool, including the eggs. Is there any chance that we don't find any, neither larvae nor eggs, but this patient is still infected? Yes, there is a chance. There is a big chance that this is a scanty infection. That's why we have to take repeated stool samples from these patients, and we should do concentration techniques in order to find the diagnostic stage. The best concentration technique is the zinc sulfate flotation technique. Can we still find this? Can we still not find the diagnostic stage in this stool, but this patient is still infected? Yes, there is a good chance about this. How is that? This happens in hyperinfection. In hyperinfection, as we said, the larvae are disseminating throughout the body without passing out of the body. That's why if we examine the stools of hyperinfected patients, we will not find the diagnostic stage there. We will not find larvae there because larvae are passing by in the body. In this case, we can do intubation, silent intubation, or the Intero tests in order to reach the small intestine to detect the presence of the rhabditiform larvae. But can we find or can we diagnose the case from any other organs? Yes. If we take pupil analysis during the migratory phase, we can find filariform larvae if it is the migratory phase. But if it is in the hyperinfection phase where the adult resided inside the lungs, this will produce all stages could be detected inside the sputum. So mainly diagnosis is done by stool analysis, but we can resort to duodenal aspiration and sputum analysis. Treatment of this case is through ivermectin, and prevention and control should be done through sanitary disposal of human excreta, mass treatment of infected patients because they are the source of infection, using disinfection of fertilizers. We don't take human stools as fertilizers. They should be disinfected just in case before being used. Skin protection, we should instruct people not to walk on the soil bare feet. And health education of people living in areas infected with this parasite. And again, using soil larvicidals once a place is known to be infected with this parasite. Finally, I'd like to add this part. You'll take it in the next lecture, but this Behrman technique is a technique in which we get a gauze and put some of the soil in this gauze. This happens when you try to do epidemiological study in order to know if this place is infected or not. We take the soil, put it in the gauze, and just close this clamp and put warm water. As we said, that the larvae here like the moisture, so when we leave it for a while, they will liberate the larvae, and larvae will be collected here. After a while, we take these larvae. Which larvae will be collected? The rhabditiform larvae. We will collect these rhabditiform larvae and we will transfer them to the lab and leave them for a while. After 3 to 4 days, the larvae of Strongyloides stercoralis will change from the rhabditiform larvae to the filariform larvae. Why do we do this? Why don't we examine directly the larvae produced here? Because the rhabditiform larvae of Strongyloides stercoralis are exactly similar to that of hookworm larvae, which you will take next lecture. But the filariform larvae of both worms are a bit different. That's why we take the rhabditiform larvae, transfer them to the lab, and leave them to develop. Filariform larvae of Strongyloides stercoralis are produced after only 3 to 4 days. They have no sheath and their tail are notched, and the esophagus consumes half the body, whereas the filariform larvae of hookworms need a prolonged time, and on the contrary, they are sheathed, pointed ends, and their esophagus is much shorter. This Behrman technique is important for epidemiological studies, for knowing the exact parasite which is present in the soil or in a specific area, in order to direct your control measures toward this area. Or alternatively, sometimes we can put stool here and diagnose the same, but it is usually used for epidemiological control measures. Thank you very much.